like to introduce our next speaker. That is Dr. Troy Lund, who many of you probably know, but for those that don't, he is a professor in the Department of Pediatrics, Division of Blood and Marrow Transplantation and Cellular Therapy. He is also Associate Director of the Leukodystrophy Center at the University of Minnesota. His talk today is going to be exploring the potential for a blood draw to replace MRIs, which could change how we practice medicine for ALD. A simple blood test would be more efficient, reduce risk, lower healthcare costs, and alleviate some of the stress and burden on families. Please join me in welcoming Dr. Troy Lund.
All right, thank you very much. So my subtitle is Changing the Practice of Medicine. Yeah, there we go. You have to be pretty close to it. So changing the practice of medicine is something that my prior boss inspired to all of us faculty members. That was Dr. John Wagner. He revolutionized transplant a couple of different ways. So when he was... You can't hear me? Dean, they can't hear me. How's this? All right, we'll go there. All right, so let's see what we have today. It's a whole new project as usual. So I'm going to talk a lot about neurofilament light chain. So, first of all, what is this thing we hear about? We abbreviate it NFL. There's a neuron stained in green, and that staining is picking up neurofilament light chain. It is really just a structural protein that gives your neurons their shape. And you can see the neuron in all its arms, and it's giving the shape to those arms and the cell body as a whole. So, and the neurofilament light chain is really, you can think of this as a scaffolding protein. So if you think of a skyscraper is built upon a steel scaffolding. And that's what neurofilament light chain is. It's part of that scaffolding. The pictogram up top shows that the scaffolding is made up of several proteins, but there are neurofilaments. They are heavy and medium and light, as shown below, and my arrow highlights the light one. And the only reason it's called light is because it's the smallest. It's about as simple as that, not rocket science. So it's a small protein that makes up the neuron. Now, interestingly, this cartoon shows that when the neuron is damaged, it literally breaks open, and some of that scaffolding leaks out. It leaks out into the brain, it gets to the CSF, and then eventually it makes its way to the bloodstream, and we can measure it in the CSF, and now we can measure it in the bloodstream thanks to new technology. So where did the story begin? The protein's been known for a number of decades. But looking at the history of it and its use as a biomarker really starts in a study in ALS. And so this group of scientists were measuring neurofilament light chain in the spinal fluid of their patients. And they noticed it was very high, as shown by the black dots at the highest levels. And the low levels way on the bottom, those are the control patients. So there was about a 10-fold difference between neurofilament light chain in the CSF of ALS patients, and they also looked at patients with other diseases and the control patients. So this is one of the first papers looking at a neurologic disease. So what about in an inflammatory disease? And this is where neurofilament light chain gets a lot of attention, is multiple sclerosis. Well, this is probably the first paper in which it was used as a biomarker. And what's interesting is that the X, or horizontal axis, is time from MS exacerbation to time of CSF neurofilament light chain measurement. And so you can see the neurofilament light chain measurement on the y-axis is very high when you're really close to an MS exacerbation. But as time passes and that MS exacerbation gets better, which it does in several kinds of patients, neurofilament light chain decreases, showing that is perhaps a marker of acute disease eruption in MS. And again, this is the first paper that indicated neurofilament light chain's potential. So that was CSF. And so we and other labs tried to measure this in the bloodstream, and it was virtually impossible because the levels are so low. But then a breakthrough technology was developed, and it is the ability to measure single proteins that are present. Usually you need to have a lot of protein around so you can pick up the signal. But a single molecule is what you can do with the new technology. And the technology is called Simoa. I'm not going to go through all the data on Simoa, but suffice to say it's a bead with an antibody. The antibody binds to neurofilament light chain in your plasma, and then a secondary antibody comes in with an enzyme that makes a substrate glow. And so you put this all together, you get a glowing bead, and you put that in basically a fancy computer, and you can pick up single molecules of neurofilament light chain. And this made it easy for us to measure these levels in the blood. And you could do this for other proteins, but it was important for neurofilament light chain because of its low concentrations. And so this is what we've done ever since. Now I just have to have a couple of slides about caveats to studying NFL. One is that your blood NFL does increase as you age. This is a large study, and it looks at patients 65 and higher, and you can see their NFL levels go up slowly with each decade. Why that is, we don't know. Is that due to some neuronal deterioration? An alternative hypothesis was that your kidneys actually filter most of the proteins in your bloodstream, and maybe it had to do with decreased kidney function. So on the right side is a graph of kidney function in older people. So from 65 to 90, your kidney function goes down. Maybe that's why the neurofilament goes up. But this is just one of those funny things about neurofilament that we have to be aware of. And then secondly, we have to have some understanding about children's levels going in. So a very large study looking at over 200 individuals from 0 to 22 years was published a few years ago. And this is what kids' levels look like from near birth, so 0. You actually drop your neurofilament light chain a little bit every year. I think it's roughly about 6% or so, something like that, until it stabilizes at looks like age 10 years. And then I showed you that at about age 65, those levels can go up. So not dramatic, and this is all population-based data. So this is not necessarily individualized people over time. But it's important to know how the test functions in the real world. And in the same study, they actually looked at kids who had a diagnosis of a neurologic disease. It could be any neurologic disease. They all grouped them together. And as shown in this paper and many other papers, those kids that are in the yellow bar graph have neurofilament light chain about 10-fold higher than the kids without neurologic disease. So just confirming what's been known for many years. So what about ALD? So I just put up one graph. So there are a number of papers on this now. Our group has published on it. Various other groups have published now about neurofilament light chain and ALD. It's a robust biomarker. This shows children with ALD on the left, and then those with cerebral disease on the right. So you can automatically see that if you have cerebral disease, your neurofilament light chain, again, goes up about 10-fold versus kids that don't, and their neurofilament light chain's kind of just near the normal level, just like any other control kid. And so again, this is not new science here, but it is new data. What happens after stem cell transplant? Again, in new data, we can show it two different ways. We can show it as a population of kids that went through transplant. The time marks below are 6 months, 6 months or 0, 6 months, 12 months, and 24 months. And so at baseline in the gray, At 6 months, you actually go up a little bit, and that's part of the inflammatory response from the transplant. And then at 12 months, you see a tremendous decrease. And then 2 years out, even a further decrease. I don't know if they get back down to baseline, but they sure do decrease from where they started out pre-transplant. So we look at this as an effectiveness of hematopoietic cell transplant, and whether you have gene therapy or transplant, you see the same thing. You can individualize the data to say what is the difference from where the kids started. So that's percent change from their baseline. And so that's why there's 3 graphs there on the right. So at 6 months from your baseline, you go up, but then from your baseline, you drop about 80%, about 50 or 60% at 12 months, and then a further drop at 24 months. And so there's 2 ways you could look at this data. So we were originally inspired actually by a clinical situation. So I saw 2 brothers. One brother's on the left came in age 12, and his LS score was 14, gadolinium positive. We discussed the role of transplant or not transplant or what would happen. Ultimately, they decided not to go to transplant. And his neurofilament light chain, 300 and something, no surprise there. Remarkably elevated, almost unreadable. I saw his brother, who was aged 15 at the exact same time, and his LS score turns out to be 15, but no gadolinium enhancement. So he was one of those kids that self-arrested somewhere in his life. He just shut off the process, and that was that. What do you think his neurofilament light chain was? I was expecting it to be super high because we had linked it to LS score and neurologic damage. Turns out it was remarkably low. It's still elevated. I mean, he's still around 30 or so, but without the blood-brain barrier breakdown, his neurofilament light chain was markedly different than his brother's. So that gave us the insight we needed to think about neurofilament light chain is a marker of neurologic damage, but it's also a marker of blood-brain barrier dysfunction. And we thought, well, maybe we could use this as a screen for the development of cerebral disease. So we started measuring it about, 5 or 6 years ago in many, many patients. I'm going to just show you snapshots of patients. So here's 6 kids there on the bottom. These kids have ALD. They do not have cerebral disease. And you can see I have one time point, and some of the kids we measured every 6 months, sometimes every year. And you can see by the different colors, you have multiple time points, and they just kind of bounce around. And so they're all below 10 or so. And what's more important is that little statistic there, coefficient of variation. That's very important. That's mathematically, how different are they from their own mean? And so how much do they bounce? They bounce around about 16%. So it may go up, may go down the next time, may go up, something like that. But it's about 16% variance from time point to time point. So the question, we have a number of patients who we were following year after year, MRI after MRI, and we're getting MRIs and plasma at the same time. And so here's an example of one. Here's a child, we got his baseline neurofilament at age 1. It's about 4. And then he had a series of MRIs. But at age 3.5, he converted to cerebral disease. And you can see what his neurofilament light chain, it went from 4 to about 8. And then we did another MRI, and his neurofilament light chain went to 10. What did his MRI look like? It looked like this one right here, and where's the disease? It's really, really hard to find. I'll try to point to it. It's right there. It is a speck of disease right in the middle of the corpus callosum. Just a tiny little speck. From here, he went to transplant and did well. But this was the first indication that, in fact, this test nearly doubled, or, I put down the change from baseline there because it's important, 56% increase. So not quite doubled, but a significant elevation. So we can look at a, let's see. Oh, and this is the follow-up MRI. Then that shows the gadolinium enhancement. And again, it's the speck in the corpus callosum. And the enhancement, which is really hard to see on this kind of a screen, is indicated by the yellow arrow there. And I tried to blow these up so you could see it. So it's just a tiny bit of enhancement in the corpus callosum, but nevertheless, it reflects the neurofilament light chain levels. So who else do we have? So we have another kiddo. Baseline was established at about 9.5. Neurofilament light chain is 2. He went on, got lots of MRIs. The next time we were able to capture his plasma happened to be at conversion. And lo and behold, near age 12, he had a new lesion that was gadolinium positive. And that's shown right here. His lesion is right here, the peduncular lesions here on the right, and they are gadolinium positive, which you probably can't see that very well, but nevertheless, they're present, and his change in neurofilament light chain is 200% from its baseline. So that was an interesting observation that suggested the biomarker is very sensitive. Interesting, the same child from another MRI, I've been following him for 6 years. He actually has a large arachnoid cyst as part of his brain structure. It doesn't affect neurofilament light chain. So even an anatomical disruption, like a cyst or something like that, his neurofilament light chain was 2. So this is good for the test, that you can have some changes in anatomy, but doesn't affect it. This child also went to transplant, did well, is fully recovered. All right, let's see. There's children, then we try to get the neurofilament light chain every 6 months or every year. Here's a child with a baseline. Looks like he's around 4 for neurofilament light chain, pops up to about 4.5, 5, moving along great to age 4, 5, 6. His MRI at age 8, we see a new lesion, gadolinium equivalent. That means we couldn't call it. And then we repeated that MRI, and 3 months later, same lesion, gadolinium positive. So again, his neurofilament light chain, a change from baseline, he went up 65%. And this is what he looks like here. It's a very tiny lesion right there at the tip of the arrow in the center of the brain. And the gadolinium is right there at the end of the purple arrow there. So very, very small. But again, robust change in NFL. He went to transplant, did well, fully recovered. And one more example here, a child we've followed again every 6 months for a very long time, established his baseline NFL at about 5 to 6. These are all mostly normal MRIs. Age 3.1, his MRI was normal, his neurofilament's normal. Age 4.2, neurofilament was normal. He got more MRIs. We didn't have plasma, but at age 5.2, his neurofilament light chain went from about 5 or 6 to about 30. And what did we find? Lo and behold, we see this lesion you can probably see, classic lesion, corpus callosum, and the enhancement down below. So classic enhancement, classic lesion. A little bit larger than the other kids. But again, the test is lockstep in sync with the MRIs. And this child did well, went through transplant, did well. This is his neurofilament light chain 1 year after transplant. You can see it's come down by about 1/3, so on its way to correcting. Whether it's going to come back down to baseline, I don't know. So that remains to be seen, but he's doing well. So I could go on and on. There's more examples of us having a baseline neurofilament light chain and then this big increase of 50 to 200%, like this child here. And same MRI correlated with a new lesion and gadolinium enhancement for the child on the left and the child on the right. Same deal, had low neurofilament light chain. And then as soon as he converted, it went up. So, being that this is rather thought-provoking, we decided to ask some questions. So, thank you to Kathleen O'Sullivan-Fortin for helping us with this focus group that we put together a few weeks ago. We just asked parents what they thought about ALD and their diagnosis and how the diagnosis changed their lives, for better or for worse. And a lot of parents commented about postpartum depression, and you heard a lot about that today as well. There's an emotional toll of getting the diagnosis, and then they all had to learn how to navigate the challenges. We talked about the standard of care, so the MRIs, the endocrine visits, and what that was like. And there's a lot of anxiety and stress about newborn screening, as one would expect. We stressed the importance of following the standard of care, which they agreed with, though you have to balance it with your family life and your child's life. And there are generally the usual concerns about risk benefits of anesthesia and contrast in MRIs, which we've talked about in the past. Some said the MRI was actually a positive experience in the older child because they get to see the images. So they get to see the evidence for themselves that there's no disease. So that was interesting. Many parents saw the benefit in using a potential biomarker in lieu of MRIs. There's some different experience in Canada and about access to MRIs and access to blood tests. So having additional information might be helpful in making the correct diagnosis. So I think that's the bulk of the data I wanted to show. Just some conclusions is that neurofilament light chain, it's influenced by a number of factors. It's influenced by inflammation, well known. It's influenced by a demyelinating lesion, but also blood-brain barrier dysfunction, which is what we found out. An increase in NFL definitely can lead to lesion detection or gadolinium-positive lesion detection. Establishing the baseline is very important because every child has their own baseline, which is why I showed the longitudinal data, because you can't just go off of one number. You have to understand where they live at. And I would argue that a potential increase of, say, 50%, that should trigger an MRI should we go down this road, because that's what we're seeing with the data. There are hurdles. The test remains technically challenging. Not everybody can do this, and nobody does it the same way. So I do everything exactly the same way, but other labs do it differently. It's hard to, so it makes it hard to compare between sites. We need to standardize the measurement. The ability to run single samples would be great. So this is all batch run. We're going to start running single samples in January. We have a CLIA certified test now to do it in my own hospital. Some of my data, I'd say you saw a single baseline. So again, establishing that baseline and its variability would be important. But once you have that, then you know how much of an increase to expect. So thank you to everybody who contributed to this and supported the project. Happy to ask any questions. Oh, how many transplants have we done in the last 5 years? Between 35 and 50.
Thanks, Troy. Great presentation. This isn't so much a question, it's more of a sort of something that came up for us recently, thinking about the emotional toll on families. We had a little boy who, for a number of years, had his MRI either the day before his birthday or the day after his birthday. Mum was worried because she'd been told, you must have the MRI, you must have it on time. And it's just to say that, asking for clarification from you, that actually if the MRI had been a week or 2 weeks before or afterwards, would that make any huge difference?
So the answer is no. The MRIs in that period of time does not make a difference. What makes a difference is if months go by. And so, the way I describe the real science is to really pin it down with exact precision, you'd have to walk in the door, walk through the scanner, and get your blood drawn every day. But for practical reasons, we can't do that. So I think this is about the best we can do, but 2 weeks doesn't matter.
Great presentation, Troy. there is a possibility of practice changing here if truly it gets to the validation. So my question is really related to the validation of this process in terms of as a replacement for MRI, and then one specific question about the possibility of the increase. We saw great examples where there was an increase in the neurofilament, and that coincided with the change in the MRI. Are there situations where there is an elevation, but there is no change in the MRI, so as in false positive neurofilament?
Now, the second question is pretty good. That's why it becomes about what is the child's variability in their baseline. So I'd say you can vary 10, 20% even, but not 50. So we never saw anybody who varied 50% that didn't have an MRI finding. Validation is hard because it's all within one lab. We'll continue to collect data alongside the MRI to strengthen the argument. But the validation, until it's CLIA certified down on the same platform at multiple hospitals, might be a little difficult.
So, Troy, I think there's a high likelihood for some overinterpretation here. Can you clarify what you're trying to say here? So you've got some really nice data on a couple of patients where you're showing baseline changes. I'm going to let you say it, but you're not advocating for transitioning right now to just blood biomarkers. This isn't sufficient data to do that, and I just want to let you clarify that yourself. You're suggesting we proceed with more study and comparison over time. Mm-hmm. Just, I'll let you say it, but that is what I think you were saying, and if you're not, I want to disagree with you on it. So
yeah. No, I would agree. It's certainly thought-provoking pilot data. Though I do believe there's a role for individualized medicine for these kids, especially those with VUSs and low very long chain fatty acids, no family history, multiple males without any hint of disease. We've been making some different recommendations. For example, kids that have mosaicism, that have no elevations in VLCFAs, yet carry an ABCD1 mutation, they're getting scanned once a year instead of twice a year. And it's mostly driven by the parents, at least the ones that I know of, because they can't live with doing it every 6 months. The MRI is so stressful that they would rather just do it once a year instead of putting the kid through it every 6 months. So there's probably an increasing role of making this more personalized for every family situation, but currently not stopping. I'm not recommending stopping MRIs today for everybody, but the data is compelling.
In your opinion.
Right. We're not recommending stopping MRIs in my opinion today, so.
Hey Troy, this is Maria. We've been emailing each other and working together online, but didn't have a time to cross paths for it today. But I'm also working with biomarkers with Troy and Patty. I'm a medical student under her mentorship, and I was wondering, Troy, about if you had the chance to measure the NFL in severe CLD cases, and if that changes. So does the biomarkers skyrocket? Is that what we expect? Because we've been seeing with the angiogenic biomarkers that is not exactly what happens with all of them. We do not expect, or we do not see that skyrocketing of some biomarkers with severe CLD cases. So I was just wondering.
Yeah, the answer is yes. They increase a log or more when it's severe, and there's actually a pretty tight correlation between severity and neurofilament light chain. And so, but our focus now is on the kids that don't have disease and when they convert, because that's the really low level stuff. Once you're 300 for neurofilament light chain, it's hard to know what to do with it, but the correlation is tight.
Have you measured neurofilament light in AMN patients?
We've done some, not as many as the German group has measured a lot. There are a couple of populations out there. There are a couple of papers out there that have done that. They are elevated more than controls, and there were a couple of patients that converted, that AMN, that converted to cerebral disease. They actually went up upon conversion. It's a little harder to interpret because they're already high. So you'd have to know their elevated baseline, and then if they converted, if they went higher. So it has been done to some extent, but not a large extent.
Question over here on the other side. Great. Wonderful talk. I'm a big advocate of neurofilament from the context of ALS, where I know it better than in CALD. And that leads me to two questions. One, you mentioned the batch processing of these samples. Does that mean that you're actually increasing the number of the amount of sample you get at baselines? You can rerun that every time again? And the other question is, are you controlling for, or should we be controlling for, body size and weight? As these children get older, potentially their brains are not, and then you have that amount of shedding that's being diluted by a whole system because you're looking at the serum. Thank you.
Yep, so they're batch. So we have run samples repeatedly. We get nearly the same result within 10%, so that's great. It's repeatable. And we've not controlled for body size and weight. I showed you what we know about babies. That was a landmark study, probably never to be repeated. Given that you actually decrease your NFL from age 0 to 10, and we're looking for the opposite effect, I think we'll just leave it at the absolute levels we're measuring in picograms per mil without controlling for anything, because the elevations are so substantial that it doesn't seem we need to control. We could do that, and we haven't.
Any other questions for Troy? If not, thank you very much.